we're doing a short video on emergency first aid. It's specifically for traumatic injuries like gunshot wounds or for things that you might find at a protest or a cardiac arrest. So this is only for life and death emergencies. This isn't a qualification or certification for anybody. It's just very basic tips for bystanders to take action and things that they can legally do before a paramedic or EMS services arrive. So the very first thing that you need to do in any circumstance where there's an emergency medical situation is put on personal protective equipment. So we're going to do that right now. So the first thing that we put on these days is a mask. It's almost necessary for every scenario and situation now, and in the past they would not have said that, but now go ahead and put on a mask if you're watching this. Here in my bag I have easily accessible box of gloves. So washing your hands and wearing gloves are the main things that you can do to protect yourself, and it's the first thing that you have to do before you can touch anybody. So the situations in which the techniques I'm going to describe are suitable are gunshot wounds to the torso, to the limbs or the head, and cardiac arrest, any cessation of breathing or heartbeat. So after we put on our PPE and before we touch the patient, we want to activate the EMS system, not the cops. We call 911 and we ask them to send an ambulance and describe very specifically what's going on. And you can ask them not to send police, which I recommend. I recently witnessed them make a situation much worse. So, you have PPP, you activate the EMS system, and now you're ready to assess your patient after you have put on your PPE and you've activated the EMS system to call more skilled professionals to come rescue your friend or your enemy. You should treat everybody if you see someone who's hurt. It's good practice to treat your enemies who are wounded. Just practice on their body. When you perform a primary assessment, you want to approach the person gently. You don't want to come running into their personal space and scare them because they're already scared probably, or they're very excited or worked up. So, if you could sit down for me.
I need to tilt this.
Yeah, I'll mess with the camera. So say my buddy here is experiencing a medical emergency. I don't know what's going on exactly, but I am going to do something when I figure it out. And the way I can figure it out is by communicating with him. So I walk up and I see him, he's guarding. He's protecting something. Something hurts him a lot right now. And I don't know what it is. But the first thing I want to do when I show up is communicate. So I'm going to see what's going on in the area. And I'm going to look around and make sure it's safe here. There's nothing crazy going on. Did somebody else in the room hurt this guy? Is it safe to come in? Once I've seen that it's safe, I'm going to address this person verbally. Right? I can see he looks somewhat alert because he's moving and he's guarding and he's holding on to something. But I don't know how alert he is, so I'm going to talk to him. So we use this AVPU. Write that down, AVPU. It stands for their level of alertness and their responsiveness to verbal or painful stimuli. Are they unresponsive altogether? So if I see him and I'm like, hey, are you okay? What's going on? If he responds, he is alert and responding to verbal cues, and that means that his airway is open, and I'm assessing him to see what kind of state he's in, so I see that his airway is open if he talks. So if I'm like, hey, are you all right?
Hurt.
Okay, he said something. He says he's hurt. I know he's in pain now, and now I can move forward with my assessment. If I come up and I say, hey, are you all right? And just flop on your side. And he's just like this, I know that he is not responsive, and he might have a blocked airway obstruction. Or he might have a blocked airway, there might be an obstruction. So, for pain in the AVPU scale, AVPU, if he's responsive to pain, if I see him guarding, I know he's responsive to pain, even if he doesn't respond to me verbally. So go ahead and sit up and clutch like you were and rock around. you're guarding, you're in pain, there's a chest injury, and maybe he has an abdominal injury or digestion, I see he's responsive to pain already. So I know that. Even if I say, hey, are you okay? And he doesn't reply, I know he's responsive to pain because he's visibly in pain. I'll go ahead and lay down. So if I show up on the scene and I say, hey, are you all right? And he's not moving, he's not guarding, and he's not responding, that's bad. That means he's unresponsive. I got to test his pain response. And I'm going to be nice because my first rule is do no harm. Right? So I'm going to come up, I'm going to assess the area, make sure that the area is safe, and look around. I'm going to say, hey, are you all right, man? Are you okay? And gently, if he's unresponsive in an emergency, I assume that he's going to give me consent to care for him when he's an adult, or she's an adult, or they. When they're an adult, you can treat them if they're unresponsive because that's implied consent. But I still need to check to see if he has a pain response. So I'm going to put my knuckle on his forehead if his forehead does not have any trauma. And I'm going to grind it there and see, oh, his eyes moved. So he can feel a little pain because he squinted when I rubbed his head. Because that sucks, right? Or I might pinch his ear or rub his knuckle on his sternum, right on his chest. His foot twitched. So I know he felt that. It sucks. It's uncomfortable. So we'll move on. So when I see that he's responsive to verbal or painful stimuli, then I know that that's where he's at. If he's unresponsive to verbal and painful stimuli, it's a very serious situation. So, continuing with my primary assessment here, I don't really have time to take vitals if his life is on the line. So what I'm going to do is I'm going to look at him, and I'm going to see what's going on. And I might do a blood sweep and search to see if he's got any catastrophic bleeding. But the main thing, after I get consent and I assess his level of consciousness, is to move directly into the ABCs. And this is super easy to remember. Airway, breathing, and circulation. So write that down right now. Airway, breathing, circulation, ABC. And you can change the order around. It should go in this way initially. When we address CPR, we'll do a different set of letters in a different order. So right now, when I want to move forward and assess, first is airway. I'm looking at him. He's got a mask on. Maybe we're at a protest. I have to take his mask off now. So I'm going to get close, but to protect myself, I'm wearing my mask. There's a possibility his body fluids could get up. So you have to consider these things. So I'm going to pull up his mask. He's unresponsive. Consent is implied. If he is responsive, hey man, you're not looking all right. Is it okay if I can treat you? He nodded. He gave me a thumbs up, even if he can't talk. That's consent. So I'm going to look at him. If he gave me a thumbs up, his breathing might not be right. I'm going to look at his belly while I put my ear over his mouth. So you want to be careful. Make sure they're not combative. I don't want to touch him with my stethoscope. So I'm going to listen. And look, I can hear his breathing. I can feel the breath on my face in this setting. At a protest in war, you might not be able to when there's a lot going on. So I look at his belly, I see this. Great, he's breathing. His airway is patent. That means his airway is clear. He's okay as far as his lungs go. And his throat, upper respiratory system is clear. So next I want to do a blood sweep. Airway, breathing, circulation, or airway, blood, circulation. I want to start up here and put my hands behind his head, support his neck. We also want to mess with the C-spine stabilization. So if I think there's been a significant mechanism of injury, I want to stabilize his head or assign one person whose only job is to hold his neck still. Now I've set my hands behind his head and I'm going to look. There's no blood. Okay, that's good. His head does not have bleeding or trauma that I can see. I'm going to look for any obvious deformities, contusions, scrapes, anything that is not completely healthy or normal. I'm going to take one arm and I'm going to sweep the whole arm. And then I'll take the other arm and sweep the whole arm. I'm going to get over them and I'm going to sweep their torso. And I'm going to look at my hands, look for blood. I'm going to sweep one leg, no blood. Sweep the other leg, no blood. Now, if this is a soldier or a protester who's a friend and they've become mentally compromised through stress or from being unresponsive and suddenly they wake up, if they're wearing a weapon on them, I want to take it off of them right away because they might panic and attack me. So if he has weapons in his pockets, I'm going to check, I'm going to set them to the side or give them to a friend, and make sure you document everything for later. You also want to document if someone does not give you consent to take care of them. You carefully document that, find witnesses. So I'm going to take the weapons away from my friend, and I'm going to put them in a safe place. Maybe he can't even see them, especially hand grenades for the soldiers and the revolutionary friends watching this. So we have airway, breathing, circulation. I need to assess that his circulation is good. Even if he's breathing, and if his pulse is strong, his circulation might not be perfusing all of his limbs. So I will take his pulse and I will take his vitals, but I'm also going to check capillary perfusion first, because that's easier. So I can just take his finger and pinch it, and I can watch the blood come back. I can use the fingernail, I can use the tip, right? He's got good circulation. That's okay. So, we can move into taking vitals in a little bit, but right now I'm still working on the emergency care for traumatic injuries. So before we move on to CPR, I want to address if we have problems with this first set of 3 letters, A, B, C. If he has an airway problem, you can use the head tilt chin lift method or the jaw thrust to open his airway. This keeps the tongue away from the throat. The tongue is the #1 cause of choking airway in people. When they're unresponsive, it's a muscle and it relaxes and it'll just slide back into your throat and it can kill you. So you can roll them to the side, or you can do this chin lift or jaw thrust method to get their nose up into the sniffing position. So while he's here, I move behind him as much as I can. There will be stuff in the way in real life, so I'm not going to ask him to move because I have to improvise as I go. So I'm going to pick him up by the back of the head, and I'm going to make sure his spine is stable. I can put my thumbs on his forehead and my fingertips on his jaw and push down on his forehead and lift up on the jaw. It takes a bit of a grip. It feels rude. You got to dig your fingers into their jawbone. So, something to consider. If they've had a serious injury, you want to use the jaw thrust and not the head tilt chin lift, because there might be a spinal or neck injury. So if that is the case, I'm resetting his head, relax, and then I'm going to take my fingers behind the edges of his jaw and I'm going to push them forward. And it's a little bit different, but you got to practice this. If you can get your hands on a CPR dummy and take the CPR certification course, this is not that. You need to get hands-on practice. And with that, you can use the dummy for doing compressions. I can't practice compressions on my friend because that is a semi-dangerous, painful practice to do to someone. So if he had a bleeding problem, right, I can open his airway, I can roll him into the recovery position for that, but that won't do any good if he bleeds out on the way to the hospital. So I have to stop catastrophic bleeding. One more note on airways. If he is not bleeding and he's unresponsive and he has drugs or any kind of thing like this, alcohol that may cause him to throw up, I need to roll him on his side in the recovery position. So what I can do is I can move one arm up by his head, and I can take his opposite knee and arm, and I will bend his knee, and I will pull him over by his shoulder and his knee, and that just rolls him to the side. Now his arm is keeping his head as a pillow, and I can put his other hand down here to help support him, and this way, if he does vomit, it'll all come out and it won't block his airway. So, we'll move you back. Thanks for being a good dummy. Now, if he does have catastrophic bleeding, right away, I want to treat that. So, the first step is gloves. Put on your gloves. Make sure you have PPE on. If he has a gunshot wound from the neck down, I want to put pressure on it immediately. If he has gunshot wound to the head, you want to put pressure on it. You just want to be careful. If their eyeballs hanging out, you want to collect this up into some bulky bandages and wrap their head gently, right? If they have catastrophic bleeding from entry and exit wound or complete amputation of a limb, you will need to use a tourniquet. So we'll go over how to use a tourniquet right now. But the first step is always pressure. Put some gauze on the damaged area and try to pressure it to stop the bleeding. There should be multiple people if you can. Have one person hold the pressure while another person prepares the tourniquet. So, if I approach this person and I see him, even if he is responsive or unresponsive, I need to make sure that he's not going to bleed to death before the ambulance arrives. So, this is a tourniquet. This is the CAT brand or CAT model you can find at military surplus supply stores or on the internet. These are great. You can reuse them. You can wash them and sterilize them. So what I want to do is get this high up his limb, at least 2 inches above the injury. I might have to use 2 if the bleeding is bad, or if there's significant damage like an amputation. So when I put this on his leg, I will have to get it all the way over. So for the sake of the exercise, I'm going to have you stand up because of the camera angle. So go ahead and recover. Thank you. And then, this chair's kind of high. Let's get a wheelchair. So sit down. So sometimes you'll have a patient who is conscious and they're able to move around and sit. You might want to move them away from the dangerous situation and sit them up. You can do drags, you can do carries, and we'll get into that in a separate lesson. So if he has a gunshot wound to the arm, upper or lower, I want to go all the way up this arm. I want to go as high as I can. Right, so we got pressure. I might have to take the pressure off and slide this thing up, and then I put it right back on again. I want to slide this arm up all the way. I'm going to cinch this tourniquet down tight. And I'm going to wrap up the rest of this Velcro when I get to the end. I'm going to free the little stick, and there's different devices, but they're all basically straightforward. You twist until it's tight. And you want to go at least 6 times in real scenarios, in real emergencies. But with most friends, they can only tolerate 2 or 3 turns when you're practicing. So I want to put this bad boy on and strap it down. Now they definitely will not die. So that's one arm. You need to stage your tourniquets so that they're set up and folded properly so that you can unfold them into a loop in an emergency situation when your hands are shaking and covered in slick blood. So I make this loop out of this tourniquet. Right? When I close it up, I'm going to extend it to where there was a previous fold. Right here I can see a bump. So I'm going to take it back to that bump before I wrap it up. So think about practicing this. You train like you fight. Right? It's ready to go. When you close it, you want to put this down. There's a stick that you twist, and the strap goes over the stick. Right there. Right? When people see the little red tab, they will know you have a tourniquet, and they can use it if they need to. So you want to open it up. It has this big loop. Here's the strap. I pull this strap loose. Now I slide this over the limb, and I pull the strap tight. So when you do this, practice 3 to 5 minute rounds of applying and removing tourniquets. When you apply a tourniquet, you need to use a marker to write the time that the tourniquet was applied. Right on their head, their neck, their forehead, wherever is visible. And you can write it on most tourniquets. They will have a tag like this, but this one is black, so it's useless. I can't write on it. But on most of them, there's a clear area here where you can write the time. But it's very small. You know, write it right on them, wherever they can see it. Okay, so another thing that we can do is treat sucking chest wounds or gunshot wounds to the chest. So, say me and my buddy here are walking around, and then we're at a protest, and there's two guys arguing up ahead of us, and they start shooting at each other, and a bullet slips past and catches one of us in the chest. We're gonna have to deal with that. So, this is called a chest seal. It's basically a sticky plastic bandage. You put them on someone's chest, on the front and back of their body, when they've been shot through, and there's penetrating trauma to the lungs. This will help you prevent tension pneumothorax and help you prevent hemothorax, which is blood or air entering into the lung cavities, and it causes the lungs to collapse, and it causes a bloating in the lung cavity, chest and the abdomen. So, if I find my buddy here, where we're standing and we're walking, here, stand with me, and we're here and we're like, oh wow, there's this crazy drama going on over there, what's this? You know, we better keep an eye on it, and then bang, 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 and all of a sudden, the dude next to me's down and I'm still watching this. Oh wow, dude's hit. So, what I need to do immediately is uncover this wound, right? So I'm like, hey bro, I'm gonna treat you, all right, okay. Yeah, so I'm gonna grab this and I'm gonna pull it up. He's gonna be laying down. I gotta clear the area and immediately apply pressure. I wanna get gauze on that thing and I wanna wrap it up. And now, especially if I can hear air hissing out, I wanna slap these on there. I'm gonna tear them open and I need these, so I'm not gonna demonstrate with these. So, you can tear it open and you stick it to them. And then with these, they'll have adhesive on them. With other kinds, you can use any kind of plastic that is not the ideal situation. It's not sterile, but you can take any piece of plastic bag or anything and stick it to this kind of wound and tape down 3 corners, because you want blood and air to escape a little bit, because anything that's too tight is not going to naturally work. So then I would roll him over. I showed you how to roll a body by bending their knee and pushing it to the side. So I would roll him over, and on the back side of this wound there will be an exit wound, and I will apply a chest seal on that side. And this is why we do the blood sweep when someone's shot, because in the stress of treating the front, I might forget that there's a hole in the back or forget to look. So you need to make sure you train to look. So, as a result of traumatic blood loss or traumatic injury or what we call multi-system injuries, someone can go into cardiac arrest. They'll have shock from this blood loss, and this kind of shock can lead to their breathing being compromised, and in turn, their heart will slow down. So, when I see someone, they could be sitting in this chair having a cardiac emergency and still be sitting upright and still be fine. They might have cardiac, not arrest, but difficulty. So when I approach this person, I want to, again, do this primary assessment. I want to see his airway, his breathing, circulation, see if he's bleeding, see what's going on. So it looks like there's just a heart problem. If he is responsive and breathing, I can give him oxygen or help supplemental breathing. One way to do that is through the rescue breaths, right? If his heart is still beating. So I need to check that. And with the trauma injuries, we did not check the vitals. With this kind of emergency, we can check the vitals. It's a little bit slower of an emergency than someone bleeding out. But it's still critical. You still need to activate the EMS system when you come across someone having a cardiac emergency. You send someone to go get supplies, whether it's an AED or whether it's just to get a phone to call the EMS system. And again, call the EMS system, don't call the cops. So when I approach this person, I'm going to say, hey, what's going on? Like, I'm going to get down on their level. I don't want to stand over this guy and be like, what's the matter with you? I want to get down here and ask consent, like, hey, can I treat you? Yeah, okay, you look like you're having a hard time. I can hear him breathing. I can see that he's still conscious, right? If he loses consciousness, I need to immediately provide rescue breaths. But if I come across a patient who is completely unresponsive, so just on me, if I see him and he's like this, he's about to fall out of this chair, I'm like, okay, this guy's unresponsive. Now I can take vitals and check to make sure whether or not his heart is actually beating. I'm going to look at his nose, I'm going to look at his chest, but I might have to do some moves and place this guy in a recovery position where I can treat him. So, I'm going to clear this area. Generally, when you move somebody, an emergency move, you want to get your hands under their arms or drag them. So I'm going to get this guy up, away from this chair, and gently down and back. And then I got to protect his head before he gets down, right? So I'm protecting his head all the way down. I might even put a pillow there, depending. For kids, if they're having trouble breathing, you can put a rolled up towel under their shoulder and they'll open their airway without messing with their face. So I see his legs aren't even, so I'm going to straighten one out because I want him to have good circulation. So ABC is for the initial assessment. When you have a cardiac emergency, you want to do CAB. So it's it's compressions, and then assessing the airway, and then assessing for, breaths? Compressions, airway, breathing. Yeah. So I want to start with compressions before I provide rescue breaths when I see someone who's unresponsive. If they are responsive and they're down, I want to start taking their vitals, whether or not they're responsive, because when I take their vitals every few minutes or so, before the vehicle comes, I can create a picture of their health in this moment, because I'm going to look at how their vitals are trending, whether they're trending faster or slower or more or less in one area or the other. And then I can create a idea of what might be going on and pass this information on to the more skilled medical professionals when they arrive. So, in order to take their vitals, I need to take their blood pressure, their heart rate, and I can also look at their oxygen level. And let's see, systolic, diastolic blood pressure. I can take the temperature too. I have all these things here in my red bag. So, the easiest way is to use equipment. So I have these devices that tell me this information right away, but you need to practice taking vitals. So, I like to take their wrist, and I will put my index and middle finger on the edge closest to the thumb. The edge of the wrist and the tendons and bones close to the thumb have a really strong pulse point, and at the same time, I want to put two fingers from my other hand on the neck. Right? I want to feel this artery here. So I'm simultaneously palpating both places to assess the circulation. And I will find a watch. I will use my watch. I will use my phone. I keep a little watch in here. I'm going to set my thermometer here and get ready to take this vital. And get my blood pressure cuff. And here's my watch. So I'll look at the watch and start taking his vitals. 15 seconds. Okay, so there was 11 beats in 15 seconds. I multiply that by 4 to get 1 whole minute of beats. So that's how many beats per minute? So that would be 44 beats per minute. Now again, this is after you've treated these life-threatening injuries as much as possible. If this is a cardiac arrest patient and they have nitroglycerin, you might help them take their nitroglycerin. And again, you want to be doing your compressions. If this person is completely unresponsive, you don't want to sit here and practice taking vitals. You need to do compressions right away and give them rescue breaths. And the ratio is I'm going to do 30 compressions to the beat of staying alive. Like da, 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 staying alive, staying alive. And then after I've counted to 30, I'm going to do 2 breaths. If there's 2 people helping, you can do 15 compressions and 2 breaths and rotate. But you need to do 100 breaths per minute or else you're not doing enough for them. So you have to really work at it. It takes exercise, do push-ups, practice doing CPR on the dummy. So after I've taken this wrist and throat, I write this down or I memorize it. taking someone's vitals. Again, this is more like a secondary assessment. After the initial trauma has passed, we've given compressions, maybe the person has recovered, and the return of spontaneous circulation, return of consciousness has occurred. So when you use a blood pressure cuff or a stethoscope, you can get these at Walmart, really cheap. You want to slide it really high up and put the listening device on the inside of the arm, right here, so that it's actually close to the artery. I get my ears in, and here, relax your arm. So I'm going to puff this up after I close the valve. It has to go over 180 millimeters of mercury. Then I'm going to slowly open the valve and listen to it. The first beat that I hear is the top number. The last beat that you hear is the second number. So he's got 100/60 right now, according to this. Again, this is the manual way. This is old school. There are tools for this, but 40% of rescue deaths related to mistakes made were a result of dead batteries in devices. So always keep the manual devices and know how to use them. And again, I'm going to repeatedly take this person's vitals until the EMS shows up, so I can tell them this person's vitals are trending better or worse, and how exactly. So now we've got 100/60, 44 beats per minute. If you think that they might be sick, you can take their temperature. These days it's much more relevant. I have a little no-touch thing here, or less touch. I need to get a better one. So I'm going to take his vitals, take his temperature. If it lets me. All right, 98.3, that's normal.